So let's start with our general pharmacology. I think at this time you all people knowing that pharmacology is nothing but a science where we study drugs and their effect on the animal, human being or simple tissues. So this is the drug and this is the body. There are two things, drug and body. What happens with the drug? We call them pharmacokinetic, PK. And everything which happens with the body, we call them pharmacodynamic. So these are the two main branches where we study pharmacology, pharmacokinetic and pharmacodynamic. So in case of kinetic, everything will be discussed around the drug. And in case of pharmacodynamic, we will do all the activities regarding this body. So if I tell you about the pharmacokinetic for the simplicity, for the sake of convenience, we have divided into 4 processes. Okay, like absorption, means drug will come into the blood circulation, and second is once it enters the blood circulation, it will distribute to different organs of our body like liver, CIT, kidney, eyes, everywhere. That is known as distribution. After distribution, it will enter into organ of metabolism. The main organ is liver, or it may enter into excretory organ, that is your kidney. Okay. So these two organs, metabolism and excretion, their main function is to stop the activity of drug, either by metabolism or by excretion. The activity of the drug will be stopped. Now the drug is no longer too active. Means these two processes combinedly we called elimination. So in case of elimination, the activity of the drug is stopped. So this is metabolism and this is excretion. The main organ, you know, that kidney, and here is the liver. So in case of pharmacokinetic, we start with first concept, that is absorption. First is absorption. If you read the language which is written in the books, what they said, absorption means a drug is administered and it will reach here in the GIT. So from the site of administration, the drug will reach into systemic or general circulation. This is the definition of A, that is absorption. So absorption is the process where the drug will enter into circulation. From the site of administration, it will enter into your systemic or general circulation. Then the first question is, this absorption, is there any route of drug administration where this absorption is absent? See, we can administer drug by subcutaneous route, intramuscular, IV and oral. There are many methods. Out of these all, there is one direct, what you call it, IV route. So in case of IV route, no need to absorb the drug. This process absorption is absent in case of IV route. So the first question, what is absorption? Site of administration to blood. And then the second question is there any route where this absorption, this pattern is absent? So that is your direct IV route. where we intravenously we inject, no need of absorption. Means if you give IV, then from here the drug will start distribution. So this was a simple MCQ asked in one of the exam, that which of the following route there is no absorption. So this is the IV route. So here is the drug and it want to reach into systemic circulation. This we call absorption. So for absorption to occur, what is important? These two barriers, 1 and 2. So for absorption, the first condition is drug has to cross membranes. Drug has to cross membranes. And these membranes are biological membranes and these are made up of lipid. So these membranes are made up of lipid. So the condition that drug has to cross, that depend on your lipid solubility. Then what is this concept of lipid solubility? This lipid solubility is further depend on ionization. In case of ionization, we say ionized molecule are water soluble and unionized portion is lipid soluble. So what is that concept? This ionization is dependent on pH. So this is the sequence you have to remember. This for absorption we need to cross these membranes. To cross these membranes, what is important? Lipid solubility. That crossing is depend on lipid solubility and lipid solubility is depend on ionization and ionization depend on the pH. So what is ionization? As you know, our body is made up of water molecules. This water molecule H2O, and this is also known as water. But this is unionized form and this is the ionized form. Similarly, suppose the AB is a drug and this is also having two forms, unionized form and ionized form. If you look the two ionized form, these ions of drug, they will combine with the ions of water. Means opposite charges will combine with each other. So we can simply say that this form, ionic form, is water soluble form. And the opposite is also true. This non-ionic form, okay, non-ionic form, this is lipid soluble. So this lipid solubility is explained by the phenomena of ionization. Means ionic portion will be your water soluble and non-ionic portion will be your lipid soluble. So if I ask you that suppose there is drug, pH and crossing. Lipid solubility depend on ionization and ionization is depend on pH. pH is always for fluid or pH is always for the media. It means suppose your drug is acidic and pH is also acidic. Same media, it will cross the membrane. Mean it will absorb, it will distribute, it will metabolize. Suppose this is your GIT and this is the circulation. So these are the membranes. Acidic drug, acidic media, it will enter into blood. After absorption, if the drug want to distribute, again it will distribute because same. Drug is acidic, media is acidic, it will cross. Similarly, drug is basic and pH is also basic, it will also cross. But what happens if drug is acidic and the pH is basic? It will not cross. It means it will ionize there. Similarly, this is basic and this is acidic. It will not cross because of ionization. So till this point, what we have learned that for absorption to happen, drug has to cross. It has to cross the membranes. That depends on your lipid solubility. And lipid solubility is dependent on the ionization. And ionization depends on the pH. Means same pH, drug will cross, opposite pH, drug will not cross because it gets ionized in the opposite pH. So, there is a drug aspirin. Aspirin is an acidic drug. And this is the blood. So, in this media, stomach is acidic, our drug is acidic, it will cross and reach into blood. So, for absorption, up to this point, what information we get? This information, that acidic drug in acidic pH will cross easily. Similarly, if you take morphine, morphine will enter, first it will encounter stomach acidic pH. Morphine is a basic drug. In acidic pH, it will not ionize. So what will happen? Morphine will move into the intestine. In the intestine, morphine, that is basic drug, will find its basic media and it will absorb. So till now, we know two things, that when the pH is same, drug will cross. But if I explain you that pH 2, 3, 4, 5, 6, all these pH are known as acidic pH. All these are acidic pH. 2 is also acidic, 3, 4, 5, 6, all are acidic. So at which particular pH, how much percentage of drug will be ionized and how much is unionized? From this concept, we only know that, okay, this is the medium, this is the drug. It will cross the membrane, but we don't know how much percent is in ionized form and how much percent is in non-ionized form. So if I move from further here to know that this much percent is ionized and this much percent is my unionized form. So for that, you need to know three things. One should be nature of drug. Drugs are mostly in pharmacology two types, weak acid and weak base. Weak acid and weak base. Second thing is pH. And third thing is pKa. So out of these three things, you know the nature of drug, pH, but the new concept is pKa. So I think in Odisha PSC they have asked about definition of pKa. So in one competitive exam they have asked about this pKa. From your lower classes, you know the pH scale 1 to 14. If I draw 14 beakers, these are the 14 beakers. Suppose 1, 2, 3, 4, 5 and then 14. And I'm adding 100 milligram drug to each beaker. My question is, in which beaker my drug will be 50% ionized and 50% unionized? This is the question. Suppose that beaker is beaker number 4. So these beakers are nothing but pH. Suppose that beaker is number 4 or that pH is 4. So I can say that at pH 4, 50% of my drug is ionized and 50% of my drug is unionized. So this pH 4 is known as pKa. So if you read from my module that one MCQ they have asked from the definition of pKa. So there are two. In that there are two options. Okay, pKa is that pH of a compound at which my drug is 50% ionized, and second option is pKa is the pH of solution at which 50% is ionized. In both the cases, pH is given. In both the cases, 50% ionized is given. So what is different? This is compound and this is solution. If you remember, in our body, there are many fluids. We have urine, ruminal fluid, and milk is also a fluid. All are having their own pH. So always remember, pH is of fluid and pKa is characteristic of a drug. So as per this MCQ, only one word they have given, that only there is a difference of only compound and solution. So pH is always for a solution, not for a compound. Because compound means what? Compound means drug. So pKa is characteristic for a drug, but pH is characteristic of a fluid. That fluid may be urine, your blood, ruminal, and milk, anything. So the answer of this question will be number 2. Means pKa is that beaker, it is that pH at which my drug is 50% ionized and 50% non-ionized. Examiner can make this question in different language wording also. It's like pKa is pH of that solution at which 50% of drug is lipid soluble or 50% of drug is water soluble. So this was the question. Very tricky question. Only one word was different and everything was same. So coming back to our 3 things where we want to know that how much percent drug is ionized. So first was nature of drug, and second was pH, and third is pKa. These 3 things combinedly we call them Henderson-Hasselbalch equation, also known as pH partition hypothesis. This equation or this hypothesis will tell you, then suppose your drug want to move from stomach to blood, then how much drug will move? It is 90% that is moving, or it is 10%, or it is 1%, or it is less than 1%. So this percentage will explained by this phenomenon called Henderson-Hasselbalch equation. So according to this equation, there is equation pH equal to pKa plus log ionized by unionized form. So if you look at, if you read my module, there is one line is written that if we increase or decrease the pH by 1 unit, means suppose pH is given 4 and I am decreasing that pH to 3, or suppose from 4 if I go to 5, 3 to 2, or 5 to 6, means for every 1 unit increase or decrease, there will be change in the ratio of ionized by unionized form 10 times. What does it mean? See, if the difference between these pH and pK is not 1 unit, let's start with the 0. Then we'll see what happens when the pH differ by 1 unit, and if pH differ by 2 unit, then 3 unit, 4 unit, 5 unit. We'll see. So starting with the 0, suppose there is no difference, means the pH is equal to pKa. There is no difference, 0. Then we will write log I divided by U, taking anti-log both sides. Anti-log of 0 equal to 1 and log will be removed. It will be I by U. Ionized form is equal to unionized form. It means what? That the both forms are same. 50% is ionized and 50% is unionized. But if I change my pH from 0 to 1, if I increase by 1 unit, this difference, if I write 1, then this equal to ionized divided by unionized. Again, I will take anti-log. This time, what is the anti-log of 1? Anti-log of 1 is 10, equal to I divided by U. So this is the meaning of that line. If I change the pH by 1 unit, from 2 to 3 or 2 to 1, 3 to 4, 3 to 2, if I change the pH by unit 1, this ratio will be 10. Then why we are studying all these things, this ratio, anti-log, log, and this I by U is 10. There is a practical application of this pH partition or HS equation concept. What is that application? Before that, let's do one MCQ. That suppose pH is 2, nature of drug. Nature of drug is acidic. For example, aspirin is the drug. Okay, and the pH is 2 and pKa equal to 4. And my question is, what percent of your drug is ionized? What percent? So putting these values, pH equal to pKa plus log I divided by U, again putting all these values in this, it doesn't make any sense. If you know, pKa means that pH at which my drug is 50% ionized and my drug is 50% unionized. pH means, or pK means that pH at which 50% ionized, 50 unionized. In the question they have given pH equal to 2, means we will move from 4 to 3, then 3 to 2. So this is the 1 unit change. So when there is 1 unit change, this ratio, now forget about this 50%. When there is 1 unit change, then this I by U, it will become tenfold. Then out of these two, which will become tenfold? That will be obtained from the nature of the drug. Drug is acidic, media is acidic, it means more will be unionized and less will be ionized. So 10%, that 10 will be ionized and 90 will be unionized. Why 90 is written below this unionized, why not here? Because when both things, previously we have seen that when both the things are same, that is drug is acidic, media is acidic, so it will remain unionized. That's why this is 90, not this. If we move from 3 to 2, again change the 1 unit, 10 becomes 1, decrease by 10 times, and it will become opposite of 1, it will become 99. So the answer of this question, how much percent is ionized? The answer will be this, 1%. If the question is like this, what percent of drug is unionized, then answer will be 99%. So that equation, like pH equal to pKa plus log I, this is the simplified form of pH partition hypothesis that 1 unit lead to change of 10. Second question in our module, it is about the aspirin. In that it is given aspirin, pH is something like 3.4 and pK, they have given pK is equal to 3.4 and pH is only blood is written. So blood means 7.4. If you see these two values, only these two, the difference between these two is of 4 unit. 4 unit. It means if I write pKa 3.4, so at 3.4, 50% will be ionized, 50 will be unionized. If I move 4.4, then 5.4, 6.4, 7.4, means 4 unit. Aspirin, my drug is acidic and pH is basic. So what will happen? It will ionize more. It will ionize more. Means in this case, the ionized portion will be more. So let's start with 1 unit change. Then 2 unit change, again 1. 3 unit change, 0.1. And 4 unit change, answer 0.01. And what is remaining here? 90 to make it 100. Here 99, 99.9 and 99.999 something. So the question was, how much percent of aspirin is ionized? That is 0.01%. And how much percent is unionized? That is 99%. It means we can, here question was unionized, not ionized. In this question we can easily explain the concept more than 99%. So from any MCQ which is related with this equation, you need to know 3 things. That is nature, acidic, second pH, that may be acidic or alkaline, and third thing is pKa, that may be acidic or alkaline. And then they will ask you percent ionized or percent unionized. So we can easily calculate, suppose pK is 3, pH is 2, 1 unit change, then answer will be 10 and 90. Which is 10, which is 90? That will depend on these first two. If both are same, then drug will be unionized. And if both are different, then drug will be ionized. So according to these two, we can divide these two things, that okay, this will be ionized or this will be unionized, or this will be unionized or this will be unionized. 90. So these things dependent on these two, and the percentage will be calculated from the number of unit changes. If 1 unit change, we put 10, 2 unit change, that is 1, 3 unit change, 0.1, and 4 unit change, 0.1. So every time what we are doing, we are changing the things by 10-fold. So this was the concept of pH partition hypothesis. So if you look into your module in 2012 LDO, there was one question. Most of the drug absorbed from, first option is stomach and second is intestine. If you look at the HH equation, Henderson-Hasselbalch equation, according to that equation, this is the stomach. Suppose drug is acidic and the media is acidic. So whole drug it should be absorbed from stomach. According to this equation, if my drug is morphine, it should absorb from the intestine, because same media, same drug, it will easily cross. Same media, same drug, it will easily cross. This is according to Henderson equation. But practically, in real life, this is not true. So to answer this LDO 2012 question, let us see. This is the stomach and this side we have intestine. Practically, most of the drug absorbed from the intestine only. Why? Number one, stomach is having small surface area. Intestine is big, having large surface area. Second, blood flow. Blood flow to stomach is less, here is more. Third thing, gastric emptying is rapid. In other words, stay time in stomach is less. Stay time in intestine is more. So these are the three reasons which explain that why a drug is, whether it is ionized form or it is non-ionized form or it is lipid soluble or whatever, most of the drug absorbed from the intestine. Look at this. This is the surface area, the big intestine. Okay. We start with aspirin. Acidic drug, it will enter first into stomach, and this is the blood flow. Suppose there are 100 molecules of aspirin. So as per the Henderson-Hasselbalch equation, my drug aspirin is acidic, media is acidic, so it will easily cross these all membranes and will come into blood circulation. It will absorb. But practically what happens? Suppose out of 100, 30 molecules absorbed into stomach. Then order will come. What order? एस्पिरिन जो है वो काफी टाइम से यहाँ पे था, अब्जॉर्व हो रहा था. स्टमक में एक ऑर्डर आता है कि अब तुम्हारा टाइम यहाँ से खत्म हो गया है, नीचे चलो. नीचे मीन्स इंटेस्टाइन में चलो. सो इवन दो इट इज acidic drug, acidic media, and 30 molecules are absorbed, but the drug will not stay here for a long time. So because of that order, it will move down, and now the aspirin will come into intestine. So in this part, aspirin is acidic, and this intestine is having pH alkaline, means my drug is acidic and the pH is basic, so it will not cross from here. But in reality what happens, a drug cannot be 100% ionized, or a drug cannot be 100% unionized. There is a ratio between these two forms, ionized form and unionized form. Always that ratio may be 99:1, that ratio may be 90:10, maybe 80:20, 70:30. It always remain in a particular ratio, never 100% ionized. If you say my drug is 100% lipid soluble, so and you inject into the circulation, suppose I inject 100% lipid soluble, so it will never cross this membrane, because to cross this membrane it has to be water soluble at least 0.1, 0.01, by some factor. So 100% lipid soluble will never cross. So there is always a ratio between the ionized and unionized form. Same thing happens with the aspirin. Aspirin has entered into the alkaline, that is basic pH. Now suppose just a minute. Aspirin has entered into intestine. Suppose 99% is opposite ionized and 1% is unionized. Means we have administered 100 molecules. Out of 100, 30 molecules absorbed, 70 remaining, and these 70 they move down into the intestine. So suppose these 70 molecules they have entered here, and out of these 70, one molecule will be unionized, means 69 ionized and 1 is unionized. Okay. So there is a particular ratio between these two forms of aspirin in case of intestine. Suppose this is the ratio, 69 and 1. So now what is the situation here? 69 molecules are an ionized form. Only one molecule will be unionized, means lipid soluble. So from the intestine, this one will enter into blood. Then again, to establish the ratio between ionized and unionized form, one molecule enter into this, 68 are remaining. Then again, from 68 one will enter, it will become 67. From 67 one will enter, then it becomes 66, then 65, 64 like this, and at the end of 12 to 24 hours, all the molecules, they will be absorbed into the circulation. So this will take time, and the intestine having large surface area, and it will provide 12 to 24 hours to the drug molecule. So within this period of time, these molecules, even they are absorbing slowly, but all the molecules will absorb into blood. So from 100, 30 absorbed, then order came कि नीचे चलो. तो नीचे चलो means कहाँ पहुँच गए ये लोग? Intestine में. So, but in this case, the surface area is more and time is also, the stay time is also more. Because of that, all the molecules slowly, they will absorb into the blood. So this is the practical concept that why most of the drugs, they absorb from the intestine. This was the real concept behind that simple MCQ, that most of the drug absorbed from the. So if they ask you according to HH equation, the answer will be stomach. If they ask you simply without any equation, most of the drug they absorb from the intestine, answer will be intestine. Why? Because in case of stomach, gastric stay time is less, and in intestine it is more. Although acidic drug, whether it is acidic or basic, all the drugs they absorb completely from the intestine. हेलो, कुछ सुनाई दे रहा है कि मैं खुद को ही पढ़ा रहा हूँ? कोई तो रिस्पॉन्स करो यार.
Yes, sir.
Yes, sir.
हाँ, तो समझ में आया कि वाई मोस्ट ऑफ द ड्रग अब्सॉर्ब फ्रॉम इंटेस्टाइन, या फिर से रिपीट करना है?
आ गया सर.
Okay. So absorption. So what we have seen till now, that drug was administered and it will reach into the circulation. That is known as absorption. So first question, when it will absorb? It will absorb, or it will cross this membrane when it will be lipid soluble. Second, how it will cross or absorb? It means they are asking about the process. So there are three processes. First is diffusion, second is facilitated diffusion, and third is active transport. Out of these three processes, they are in many exams they have asked, out of these three, which is most common? Diffusion is the most common method. Diffusion is the most common process where the drug will absorb into the general circulation. And out of these three, which is the most rapid process, that is active transport. This is the rapid one. Why rapid? Because it utilizes energy. और जो भी काम हम एनर्जी से करते हैं वो जल्दी होता है ना. So diffusion is the most common method and active transport is the rapid process. So the first process is the diffusion. There is one simple law known as Fick's law. According to this law, rate of diffusion is directly proportional to concentration gradient. This law states that if we increase the concentration gradient, it will cross. Suppose this is the membrane and there is more molecules this side and less this side. So it will cross from high to lower concentration. This is the simple Fick's law. If we remove this constant, then this will convert into dP by H. H means thickness of this membrane. If I make this membrane very much thick, suppose in case of chronic inflammation, there is mastitis, and in case of mastitis, chronic inflammation, things become fibrotic, very much fibrotic. So if you inject, if you give a drug, it will find some difficulty, or it is very hard for the drug to cross this membrane because the membrane has become thick. So this H will tell you thickness. Rate of diffusion will decrease with increase of the thickness. And second is P, partition coefficient. So partition coefficient means solubility in oil versus water. For example, thiopentone. Thiopentone has partition coefficient of 10. It means thiopentone is 10 times more soluble in oil as compared to water. And D is diffusion coefficient. So these all are constant, and this is the concentration gradient. So rate of diffusion directly to concentration. More the concentration gradient, more it will cross, more the diffusion. And this simple diffusion is independent of ATP. No energy is required. It's a simple process. No carrier are required. Then second, facilitated diffusion. In case of simple diffusion, suppose this is simple diffusion, lipid solubles can easily cross the membrane. But in case if you inject water soluble drug, that drug needs something to cross from this membrane. Water soluble drug, they need one transport known as carrier molecule or transport molecule to cross to the opposite side. So facilitated diffusion, there is requirement of carrier or transfer protein, and these transfer protein are saturable. They can carry at a time one molecule. So this process is saturable. In this process, no ATP required. In this process, carrier molecule is required. Then next is active transport. Active transport is of two types, that is primary or secondary. Primary active transport utilizes ATP because in the name itself ATP, and the secondary active transport is ATP independent. So the energy which comes for the secondary active transport, that comes from the concentration gradient. So this is a small difference between primary active transport and secondary active transport. And the last transport process is known as efflux transport. This efflux transport is carried out mostly by P glycoprotein. That's the same P glycoprotein which is related with your colibrid. In ICAR 2018, they have asked about the colibrid P glycoprotein. Suppose this is the nervous system or brain. This is the brain, and brain is covered with blood-brain barrier. The blood-brain barrier do not allow molecules to enter from the blood. This entry is not there. So this is the cell in the blood-brain barrier. By chance, some molecule from the blood, if they enter, then there is one pump known as P glycoprotein. This is known as efflux pump. It will kick the drug out of the brain, and this pump is found in blood-brain barrier. And this pump is a protein, and this is expressed by a gene, that is MDR1. So this was your ICAR 2018 MCQ. That colibrid are more susceptible to ivermectin. Because normally, when there is ivermectin, the blood-brain barrier is having peak glycoprotein which throw the drug outside. So it will not concentrate in the brain and no toxicity. But in case of colibrid, there is MDR1 gene mutated. Mutation of MDR1 gene. Because of that mutation, P glycoprotein is non-functional. Then the drug will enter into the brain and it lead to toxicity. So with this transport, they have asked one MCQ in 2018. So this was the absorption related all topics. Now factors affecting absorption. Small factors like size. If size is small, it will absorb more absorption. Second is blood flow. If blood flow is more absorption. Third is surface area. If surface area is more, absorption will be more. So these are the factors which are affecting. Then next is hepatic first pass. If hepatic first pass is more, then absorption will be less. Then what is this hepatic first pass? There is one concept known as first pass metabolism. First pass metabolism means we have administered one drug that entered into the CIT, and this is the liver and this is the general circulation. So first the drug will cross this membrane, it will absorb, then it will reach into the portal circulation, and from the portal circulation then it will enter into systemic circulation. So these are the two parts where the drug will start its journey. This is the portal vein and it will reach into systemic circulation. Suppose 100 molecules are given, out of 100, 20 comes out into feces and 30 are eaten by the liver, and here reach only 50. So the first pass metabolism may be occurring at this level, intestine. For example, catecholamines. We give catecholamine by IV route, IM route, parenteral, not orally, because there are many enzymes digest them. Then liver, there are drugs like LPG. These LPG drugs are also metabolized by the liver. So this is known as first pass metabolism, having two components, intestinal first pass or hepatic first pass. There are some routes where this first pass metabolism will not be there. It means the drug will enter directly into the circulation, like sublingual route. Sublingual route, like IV route. Sublingual route, IV route. Drug will enter into the general circulation. It will not enter into liver. So no first pass effect. Then the last topic of absorption. See, out of ADME, absorption is one. Then again, metabolism or distribution and excretion, 1 or 2 MCQ they will ask. So last is how to measure absorption, means determinant of absorption. Determinant. There is only one determinant, that is bioavailability. ICAR 2017. They have asked the definition of bioavailability. Means if we administer 100 molecules here, then out of these 100, how much fraction, how much percentage will enter into my general circulation? Suppose 50 reach there, then bioavailability will be 50%. If 20 reach, that will be 20%. It means If 50 molecules reaches in the circulation, means 50 are lost in the path somewhere. So there are two things. One is GIT, one is liver before reaching the systemic circulation. So the drug may lost in feces, may be metabolized in GIT. So the factors which affect this bioavailability is the absorption. If my drug do not absorb, it comes out into the feces, then bioavailability will also decrease. Second, if liver digests some of the drug, then also it will reach less. So second factor is hepatic first pass. Hepatic first pass. So this was the MCQ asked in Odisha PSC assistant surgeon. That bioavailability depended on what factors? Absorption and hepatic first pass. And how to measure the absorption? Only by this parameter, bioavailability. So this finishes our topic of absorption. So in case of absorption, let's do a review. We have studied what is absorption. Second, the factors affecting this absorption. And third, how to measure this absorption or determinant of absorption. These were the three topics related with the absorption. Similarly, after absorption, the drug will enter into circulation. From here, what start? Distribution. So we will study distribution, then factors affecting distribution, how to measure distribution. A small topic. Similarly, metabolism. That is factors affecting metabolism and how to measure this metabolism and excretion. So our next topic is distribution. So after absorption, from here we have reached at this point. From this point, what start? Distribution. So the first question is, suppose we have given 100 molecules and out of 100, 50 reaches into the blood, that is absorption is 50%, and then this is liver or that may be eyes. If 25 molecules reach at this point, then my question is, what is the distribution percentage? It is 50 to 25. It is 50% or from 100, 25, or it is 25%. So what is the distribution in this case? See, distribution means drug will start its journey from blood, not from this point. So we start the distribution from 50, and from 50 we are distributing 25. The answer will be 50%. So we always measure distribution from blood compartment, not from what we given already here, because that is a part of absorption. So this is the distribution from the blood to various organs. That may be your liver, GIT, stomach, intestine, muscles, anything. So if 50 reached here, so this 50 will tell you, suppose there is 25, then distribution is 50%. So similar to absorption, we are here in the blood compartment. So now the drug want to move into various organs like liver. Suppose drug want it action on the CIT, or that may be bone or any other organ. Again, to reach this point, it has to cross two membranes, one this and one this. If it want to reach here, then one membrane this and one this. Again, drug has to cross membrane. So for drug to cross membrane, the most important factor is lipid solubility. It means similar to absorption, this for distribution to cross membrane, what is needed? Lipid solubility. Number one. The first factor is needed is lipid solubility. So we know the lipid solubility is dependent on ionization, ionization dependent on pH, that we already done. So the second factor is plasma protein binding. Third factor is different kind of barriers. So these are the factors on which distribution depends. Why these factors will not they were not there in case of absorption? Because in case of plasma, we have plasma proteins like albumin, like this. So for absorption, we were just behind this step, not entered into the blood. So we were here for absorption from this to so before that. So after reaching the blood, one component is this, okay, it has to cross membrane, lipid solubility, but there is one more factor come into play, that is our plasma proteins. These are the plasma proteins. In ICAR 2019, they have asked one question on this topic, plasma protein binding. Okay, suppose a drug bind with plasma protein, can it cross the membrane? Answer is no. Why? Because a drug is always a small molecule and plasma protein is also a small. But when they combine together, it becomes a large molecule. And large molecules, they cannot cross membrane. So this is known as plasma protein binding. So plasma protein binding will tell you that drug exists in two forms. Drug exists in two forms. In absorption, we have studied drug exists in two forms, ionic form, non-ionic form. Similarly, here in distribution also, in case of circulation, if you find drug exists in two forms, that is free form and the second is bound with the plasma protein. This is bound form. So only the free form is able to cross and is able to produce its action. This bound form will not cross the membrane, it will not metabolize, not excreted out because of the bound nature. So what is the significance of this bound form? So the question in your ICAR exam, it was that what is the significance of this binding? So free form and bound form with the plasma protein. So first significance is distribution. There are 4 D. The first D is distribution. If it is in bound form, can it distribute? No. Distribution will be less. So in bound form, the distribution will be less. Second significance is displacement. Displacement. Displacement means there is plasma protein. Drug will bind here. These are the binding sites. Drug can bind anywhere. Suppose there are two drugs. One is warfarin. The binding of warfarin is 99%. Only 1% is free and 99% is bound form. If I administer phenylbutazone, this phenylbutazone, this drug is also having affinity for the albumin. So these two drugs compete with each other. There is a competition with this. Suppose one molecule of this win this competition, then it will displace one molecule of the warfarin. So initially there was one molecule was free and it was producing its action. Now one more molecule is free because of this phenylbutazone. So in the circulation there are total 1 plus 1, 2. Normally this one molecule was able to produce its action or produce its effect, but now in this case the effect has become doubled. Means I can say that warfarin is now become toxic because of this displacement interaction. Concentration of free form will be 2 times. So this is known as drug displacement interaction. There are two drugs competing, one displaces the other which is having high affinity, and the other drug which is displaced, that concentration will increase. Like here warfarin from 1 to 2%. There is one more example in case of human beings. That is also an example of drug displacement interaction, and that is known as Kern-Icter. So in case of human being, what happens is this blood-brain barrier is in case of infant, this blood-brain barrier is not developed completely. So in case of infant, in their blood there is molecule of bilirubin. Bilirubin combined with albumin. If we give sulfonamide drug, sulfonamide will compete with the bilirubin and displace this bilirubin, and this bilirubin will enter into the brain of the infant. This bilirubin will enter and it will get deposit into the midbrain. That may lead to this condition, Kern-Icter. So this is an example of drug-drug interaction where there is a plasma protein and there is bilirubin molecule, and if you give sulfonamide that is having more affinity, it will displace the bilirubin and the bilirubin molecule will cross this blood-brain barrier which is physiologically weak or which is incomplete or underdeveloped. So in case of human being, this is another example of drug-drug interaction. Next factor with distribution was barriers. There are many barriers like blood-brain barriers, like placental barriers. These barriers, they do not allow the a drug to enter into the brain, or it does not allow to enter into the fetus. So these are the barriers. So these barriers decrease distribution. These variables, they decrease the distribution. Next is how to measure distribution. That is determinant of distribution, or how to measure distribution. In case of absorption, the parameter to measure that was bioavailability. But in case of distribution, that parameter is known as volume of distribution. That is known as volume of distribution. That is VD. This VD concept is very important. So please concentrate here. There are suppose 3 beakers and the volume is 5 liters each, 5 liters. Suppose I gave 100 mg to this and 100 mg to this and 100 mg to this. And if I measure the plasma concentration, that will be 100 mg dissolved in 5 liters. So it will be 20 milligram per liter. The volume of distribution having one formula, that is dose divided by concentration. Dose or amount. What is the dose? 100. 100. Concentration is, plasma concentration is 20. So volume of distribution is 5 liter. It means what? My blood is 5 liter and the VD is 5 liter. It means distribution is 0%. Distribution is 0%. 0% means the whole drug is present in the plasma only. This whole drug is present in the plasma. Look at the second case. Suppose there are some small organs. Out of this 100, 50 is eaten by or destroyed by these. Only 50 is present in the plasma. Only how much is present in the plasma? 50. So 50 milligram present in the 5 liter. So the plasma concentration will be 10 milligram per liter. If I calculate the VD in this case, that is dose by concentration. What is dose? 100. What is concentration? This is 10. So my VD will be 10 liter. So look at this concept. Distribution was 0%. But in this case, distribution is 50%. Volume of distribution was, VD was 5 liter. Here VD is 10 liter. Distribution was 0%. Here the drug distributed 50%. Only 50% is in blood. You can see only 50. In the third beakers, if I make a big eater, that is liver. Liver is a big eater. It will metabolize most of the drug. So suppose the liver eat 90 and only 10 is present in the plasma. So if I calculate plasma concentration, I will find 10 mg present in 5 liter plasma. That is nothing but the 2 mg per liter. And if I calculate VD, then those 100 divided by 2, that will be 50. So in this case, the distribution is 90%. So if you compare these three things, out of these, which is exactly represent our body, this also represent our body because we have metabolizing organs like liver, like GIT, different organs. But in this case, there is nothing to metabolize. So if we look at these three conditions, in the first case, VD is 5 liter, blood or plasma is 5 liter. It means whole of my drug entirely it is present in plasma. So if the drug is not leaving plasma or not entering into the tissues, it means its distribution is 0. In second case, VD is 10 liters, means distribution is 50%. Out of 100, 50 is present in blood, 50 enter into tissue. Distribution 50. In third case, 90 enter into this, 10% is there. Means distribution means from the blood how much entry into tissues? 90. Distribution is 90%. And VD here is 50. So the conclusion of this concept, what is the conclusion? If you look at all the three cases, as the VD increases, 5 liter to 10 liters, then 50 liters. As the VD increases, distribution also increases. It means more VD, more distribution. Less VD, less distribution. In other words, we can say this is the blood, and this is also blood, and these are the tissues. Okay. If drug A and there is drug B, it is having high VD, more VD, so it will more distribute. As the VD increases, distribution increases. More VD means more distribute, means more will enter into tissues, less will be in the plasma. Opposite to that, less VD means less distribution, less drug will enter into tissues, it will remain inside the plasma. This is the concept of VD. That as the VD increases, distribution increases. Low VD, low distribution. High VD, high distribution. Then why we call it apparent? Why not call it true VD? There is one term, apparent. Apparent volume of distribution. Why apparent? Why not true? Why not true? This apparent means hypothetical. Apparent VD is a hypothetical concept, because if you want to know about the true VD, suppose I want to calculate true volume of distribution. We have administered 100 mg to this human being. Okay, 100 mg. Suppose out of 100 mg, in the blood it reaches 50. Other 50 may be destroyed in the feces, urine, wherever. In the circulation it reaches 50. Out of 50, for example, 10 enter into stomach, GIT, 10 enter into kidney, and 10 enter into heart, and 10 will enter into lungs. So out of this 100, I have administered 100, 50 reaches into my circulation, and this 50 will distribute 10 into heart, 10 into GIT, 10 into kidney, 10, and suppose 5 into bones, these bones. Okay, it is distributed like this. And if you want to calculate true VD, true volume of distribution, तो आपको क्या करना पड़ेगा? You have to remove these organ outside. आप एक एक organ को बाहर निकालोगे, किडनी को बाहर निकाला, और इसमें से आपने मेजर किया, अच्छा इसमें जो डिस्ट्रीब्यूशन था वो मुझे मिला 10. I have found 10. फिर आपने क्या किया? हार्ट को बाहर निकाल लिया, and you find 10 mg.
Speak in English, bro.
Okay, so these are the organs where the drug is distributed. Suppose out of 50, 10 enter into heart, 10 into GIT, 10 into bone, 10 into this, and 5. True VD means if you want to calculate true VD, you have to remove all the organs separately and you try to calculate individually. Okay, this is the drug distributed in this part, this is this part. So we have calculated true VD. But what happens with this individual? Obviously, if you remove all the organs, he will die. So we cannot calculate true VD. So this is the truth of VD. That we cannot calculate true VD, because to calculate true VD, you have to remove all the organs. That is not possible to remove all the organs and calculate. So we rely on a hypothetical parameter known as apparent VD. So in case of calculations, what we call apparent VD, we can believe this concept that this is equivalent to true VD. So apparent VD is equivalent to true VD. Okay, distribution part is over. I think this was given in your model. Next is metabolism. Next is metabolism and excretion. These two organs combinedly we called, what they do? Elimination. Elimination means to stop the activity of a drug. How to stop? The liver metabolize the drug with the help of some enzymes. It will stop the activity. How the kidney will stop the action? It will excrete the drug out of the body. So in both the cases, either you metabolize with the enzymes, you are stopping the action. In other case, kidney, it is throwing the drug out of the body. So elimination means metabolism plus excretion, where we stop the activity of drug. So in case of metabolism, there are two MCQs given in the module. The first MCQ is, what is biotransformation? And second is, aim of biotransformation. These two are different MCQ. First is the definition of biotransformation. It means we are doing chemical alteration inside our body. Second is the aim of biotransformation. The aim is to make a drug water soluble. Aim of drug is not to inactivate. To inactivate a drug, this is not the aim. Because a drug for our body is a foreign substance. Our body doesn't know that this drug is, I have to convert it in inactive form or more activate form and other forms. It simply knows that I will make it water soluble and throw this out of my body. So to do that, the biotransformation will convert this lipid soluble into water soluble, or it will convert into a polar molecule, so that kidney will remove this out of the body. So this is the main aim of biotransformation, to make a drug water soluble. And what is biotransformation? That is chemical alteration of a drug in the body. And what are the functions of biotransformation? That include inactivation of a drug, more activation of a drug, and that may be no changes in the activity. And there is a concept of prodrug. Suppose there is PCM, paracetamol, and there is one prodrug, phenacetin. Why we make prodrug? In case of GIT, we give one drug, and this drug is digest or destroyed by the acid. Then we attach one group with the drug, and this star protect the drug from the acidic media, and it take the drug into basic media so that our drug easily absorb and reach into the circulation. So prodrug concept means it is an inactive form of the drug which becomes active. It's maybe inside the GIT or maybe inside the liver. So what are the molecules we combine? This star may be ester bond, ester molecule. In our body we have many estases enzymes. So suppose this is our drug and we combine this star and this is the ester bond. Our body having esterase enzyme. So after absorption inside the plasma we have many esterase enzymes. They will remove this bond, remove this molecule, and our drug is free to produce its action. So this is the concept of prodrug, that is nothing but inactive form of a drug. Inactive form. It will become active inside the plasma or it will become active inside the liver. So these are the functions. So metabolism or biotransformation, there are two phases. One is phase 1 and second is phase 2. Phase 2. In case of phase 1, suppose we have lipid soluble. We add functional group. We make it more reactive. So this is the main aim or main function of phase 1, where we add a functional group or we can expose the functional group which is already present in the molecule. So this phase 1 is also known as non-synthetic. Means we are not synthesizing something, we are making the drug more reactive, so that after becoming more reactive, in case of phase 2, we can react. Now this is reactive, so we can add something big molecule, water soluble portion. That may be your glucuronide molecule. Glucuronide molecule. Then with the phase 1 product, we paste one water soluble thing, and this will become complete water soluble, so that kidney can remove this out of the body. So phase 1 and phase 2 reactions. Phase 1 reactions, they make the molecule more reactive by adding the functional group or the molecule itself having a functional group, but that is not exposed, so it will expose that functional group and make it more reactive. Once it becomes more reactive, it will combine something known as water soluble molecule. For example, glucuronide, acetylation, sulfation, these molecules, and then it will excrete it out. So all these things never happen in a sequence. If we give aminoglycoside, okay, so aminoglycoside are polar molecule. So no need to go into phase 1. They will just coming out of the body through the kidney, because they are already water soluble drug. So water soluble drug will come out without passing this phase 1, this phase 2. So if aminoglycoside are already water soluble, so no need to go into phase 1, phase 2, they will out of the body. Similarly, some molecules, they come out from phase 1 and excrete out. Some do not undergo phase 1. They directly enter into phase 2 and excrete it out. And aminoglycoside do not undergo phase 1, no phase 2, because they are already water soluble. So water soluble things will be removed by the kidney. Then what are the reactions which include? So in case of phase 1, the most common reaction is the oxidation reaction. So these phase 1 reactions are carried out by one family of enzymes, CYP 450 enzymes. In 2020, there was one MCQ that which of the following enzyme carry out majority of the reactions. So that answer was 3A4. CYP 3A4. And the second answer, second 2D6. So these are two enzymes, 3A4 and 2D6. They carry out most of the reaction. In the options, if both are given, then 3A4 will be your answer because it carry out these phase 1 reaction more than 2D6. But if both are given, then answer will be both. And if they are asking specifically about, that answer will be 3A4. So these are the cytochrome P450 molecules. P for pigment and 450 is nothing but the wavelength that is absorbed by these pigment. So phase 1 reactions, out of phase 1 reaction like oxidation, hydrolysis, reduction, many reactions, examiner will ask you which is most common. The answer will be oxidation. Out of phase 2, which is most common, that is glucuronidation. Glucuronidation. And most of the phase 1, or you can say all phase 1, they are carried out by microsomal enzymes. There is only one phase 2. Only one phase 2 reaction that is carried out by microsomal, and the answer is glucuronidation. All other are carried by non-microsomal enzymes. So what are microsomal enzymes and what are non-microsomal enzymes? So these are the drug metabolizing enzymes. These are nothing but the normal enzymes which are metabolizing our feed ingredients. So we call them drug metabolizing enzymes, called microsomal, non-microsomal. Means those present in smooth ER, they are known as microsomal. Other than smooth ER, they are non-microsomal. So these are the two categories of reaction. Microsomal enzymes, they can be induced, they can be inhibited, but cannot be induced and they cannot be inhibited. These are enzymes. We have genes inside the cell, and genes do gene transcription, then translation, then we make proteins, and these proteins are the enzymes. So these microsomal enzymes, they can be induced, means their number can be increased. These can be inhibited, means their number can be decreased. So these microsomal enzymes, their number can be increased, that is induced, or their number can be decreased, that is inhibited. But non-microsomal, they are neither induced nor inhibited. So what is the clinical importance of this concept, induced or inhibited? In case of microsomal induction and microsomal inhibition, in this case all the things increases. In case of inhibition, everything decreases. Like number of enzymes increases. If number of enzymes increase, they will metabolize more, so metabolism increases. If metabolism increases, you need to increase the dose. If you do not increase the dose, then your therapeutic effect will decrease. There will be failure of treatment. In case of inhibition, everything decreases, like number of enzymes decrease, metabolism decrease. You need to decrease the dose, because if you do not decrease the dose, what will happen? Toxicity will happen. There will be toxicity. Because the metabolism is because of enzymes. More the enzymes, more the metabolism, then you have to increase that dose. Otherwise, there will be failure of treatment. So for induction, everything increase. For inhibition, everything decrease. So in case of metabolism, phase 1, phase 2 are important. Then example of these induction or inhibition, as I have given GPRS, cell phone. That is glycophyllene, phenobarbital, rifampicin, smoking, and carbamazepine, CBZ, and the phenytoin. So you can remember easily from this mnemonic CPRS, cell phone. These are the enzyme inducers. And enzyme
Can you
inhibitors
say
are
once
vitamin
more?
K. What? These are the example of enzyme induction. These are the drugs like glycophyllene, phenobarbital means barbiturate, rifampicin, and this is the smoking, and cell phone, that is CBZ, and P is the phenytoin. So these are the drugs, they cause increase the gene transcription and they lead to increase in number of enzymes. So more the enzymes, more will be the metabolism, and you need to increase the dose, otherwise it will not be effective. If I give you one example of this induction, okay, suppose you have 50 enzymes. Suppose you have 50 enzymes. This is the drug. 50 enzymes. I have given 100 molecules and 50 enzymes. They will metabolize 50. If I give another drug, A, and it is an inducer, means it increases the number of enzymes. So from 50, they will become 90. Again, I have given 100 and enzymes are now 90. Because of this A. So now they will metabolize 90. So what is left? 10. How much metabolize? 90. So in this case, to get the same effect, suppose 50 are the molecules, they are responsible for the action, and now only 10 are left. We have to increase dose from the 100 to make it 50. We need to add 40 more. Then it will be plus 40. It will become 50 because this is the 50 which is responsible for the action. So this is known as enzyme induction. And in case of A, you can put any example like rifampicin. Rifampicin. Suppose there is a patient on warfarin therapy. Okay, there is a patient on warfarin therapy. After 6 months, what happens? He developed tuberculosis. And the doctor started giving him rifampicin. So after giving this rifampicin caused the enzyme induction. Now the drug was the patient was on warfarin therapy. Now this warfarin therapy, because of this rifampicin anti-TB drug, it will increase the enzyme number. These 100 will be metabolized into 10, and now my warfarin therapy will not be effective. So there will be failure of warfarin therapy. So to prevent this failure, we need to increase dose. So this example explains why this concept of induction is more important. There are some fruit juice like grape juice also. Some juice are also there which increase the induction. They increase the metabolism of drug. So these grapes juice, they are not allowed, not recommended with some drugs. So this was the concept related with the enzyme induction or enzyme inhibition. So next is excretion. I think in metabolism I have covered phase 1, phase 2, enzymes and this. Okay. Metabolism is over. Next is your excretion. The main organ of excretion, as you know, that is kidney. In case of kidney, there are many processes. Only 4 processes, not many. First is glomerular filtration. Second is tubular secretion. Third is tubular reabsorption. These things happen at the level of kidney. So, if we look at the glomerular filtration, both water soluble, lipid soluble drug, both drugs can filter here because the structure of glomerulus is porous. Structure is porous. Whether it is water soluble or lipid soluble, both drug will cross and they are filtered. But this second process, tubular reabsorption, that depend on the lipid solubility. If the drug is lipid soluble, it will be reabsorbed back. If it is water soluble, it will be excreted out. So this is glomerular filtration. In case of penicillin, 20% glomerular filtration occurs and 80% tubular secretion occurs. So what is tubular secretion? For tubular secretion, that is an active process mostly. This is the PCT cell and this is the blood. And from this, it will secrete into the lumen. This is known as tubular secretion. But this tubular secretion is via one protein channel. So penicillin, 80% they are secreted this. So because of that, they have short half-life. To prolong this half-life, to increase this half-life, what we do, we add one molecule, probenecid. What is the role of probenecid? This probenecid molecule has high affinity for this transport pump. Because of high affinity, it will combine with this and then the penicillin molecule unable to combine and secrete it out. So penicillin molecule will again circulate in the body, in the blood. So in this way, we can increase the T half of the penicillin. So this is the tubular secretion where interaction occurs. We can utilize the probenecid molecule to increase the half-life of penicillin. Tubular secretion. And at glomerular filtration, both form can be filtered, and in case of reabsorption, only lipid form can reabsorb, water soluble come out. Then next, determinant of elimination. How to measure elimination? There are some factors. The first is T half, that is half-life. In 2017, they just asked definition of the T half. It is the time in which plasma concentration of drug become 50%. Suppose initially the concentration is 100. After first T half, it will become 50. After 2 T half, 25, 3, 12.5, then 6.25, 3 and 4. So in this way, after every half-life, concentration keep on decreasing by 50%. So this is the T half. The clinical importance of T half. T half will tell you dosing interval. If T half is more, so you will give that drug once a day or twice a day. That is frequency. If T half-life is less, having 1 hour, 2 hours, then you need to administer that drug multiple times. So T half will explain dosing interval. First thing. Second thing, what T half tell you? T half will tell you steady state concentration. Steady state concentration. Initially, if we administer a drug through the IV at a constant rate, suppose we administer drug 110 mg per hour something, then this is the rate of administration. So initially, rate of elimination was 0. As we keep on administering, the rate of elimination from 0, it start increasing. One time will come that rate of administration will become equal to rate of elimination. This state is known as steady state. And this state will reach in 5 half-life. This was the MCQ in your ICAR exam. That steady state concentration reached in how many half-life? So 5 half-life are required to become this drug concentration, plasma concentration steady. What does it mean? Suppose I draw a graph, okay? And this side, half-life. First time, if I give 100 unit of drug, then in first half-life, it will become, suppose this is the first half-life, it will become 50. Again, I give 100, it will become 150. In next half-life, it again become half, that is 75. Again, if we give 100 plus 1 becomes 175. Then in the third half-life, it will become half of this 8 and 7, 87. Again, it will be, if I add 100, it will become 187. Then half of that will be something like 29 and 3, 93. Then again, this. So, as we doing again 100, again half, so a time will come that with 5 half-life, it will become stable. This concentration becomes stable. This is known as steady state. So this steady state is in 5 half-life. So this is known as steady state, and this is achieved in 5 half-life. So T half will tell you 2 things. One is dosing interval, and second is the in how much half-life you will reach the steady state concentration. And third thing, number 3, T half will tell you elimination of drug. Suppose 100, then 50, then 25, 12.5, 6.25, 0.25, then 3.25. They say when drug is less than 5%, we assume that drug is eliminated from our body. So how many half-lives are required to eliminate a drug? 1, 2, 3, 4, 5. So this was the MCQ in your ICAR exam. That to eliminate a drug from our body, how many half-lives are required? 4 to 5. 4 to 5 hours. And exact answer is 5 half-lives. Because when the concentration falls below 5%, we call the drug is removed from our body. I will give you 2 examples of this elimination. There is one drug that is beta blocker. We call them esmolol. Okay, it is having half-life of 10 minutes. Having half-life of 10 minutes. So this drug will be eliminated from our body in 4 to 5 half-life. Means I can say 40 to 50 minutes. So 50 minutes are required to eliminate the drug from our body. This is the meaning of half-life for the elimination of drug. In 50 minutes, the drug will removed. Suppose there is one drug, amiodarone. It is having half-life of 8 weeks. So similarly, it will take 4 to 5, means 40 weeks are required to remove the drug completely from our body. So T-half will tell you 3 things. One is the dosing interval, and second is in how many half-life you will achieve the steady state, and the third thing is removal of drugs from our body. Next and last topic of today is order of kinetics. There are only 2 orders, first order and zero order. Rate directly proportional to concentration. That is, suppose drug A. If I put 1, it means the rate is directly concentration. If I put 0, this is zero order, means the rate is independent of concentration. Something power 0, that becomes 1. It means rate is independent of the concentration. This is your zero order. And 1, concentration power 1, means rate is directly proportional to the first order kinetic. So the definition of first order kinetic is, there are 4 MCQs they ask you. First is first order kinetic, and second is 0. F for fraction. F for fraction. A constant fraction is eliminated per unit of time. Suppose we have 100, then 50, then 25, then 12.5, then 6.25. 1 hour. So in every 1 hour, 50%, or if you make it fraction, then divide by 100, it will be 0.5. So 50% every time. 50%. So every time 50% is eliminated. So this percentage or this fraction is constant in case of first order kinetic. But in case of zero order kinetic, what is constant? Amount. Suppose this is 100, then 80, then 60, then 40. So every time 20 is removed. 20 is removed. So this is the meaning of constant fraction. So we call first order kinetic as constant fraction kinetic, and zero order amount, constant amount is eliminated per unit time. What is that unit time? Maybe 1 hour. So the next question in this first order and zero order kinetic, they will ask you three things. In module I have given. One is rate of elimination, rate of elimination, clearance, and third is the T half. These are the three things they will ask you. So first we will look at the T half. It's very simple. T half. Half-life every time it is 1 hour. Means 50% eliminated every time half-life is constant. So for first order half-life is constant, that is 1 hour. Because the definition of T half is the time period in which the drug become half. So in first case drug become half in 1 hour. In second 50 to 25, 50% 1 hour. Again 50% 1 hour. But in case of zero order, 100 to 80, this is not 50%. 50% will lie somewhere here. This is 50. So from 100 to 50. From 100 to 50, it will take how many half-life? 1 hour, this is 1 hour, and from 60 to 41, so this is half. This is half, so 1, 2.5. So 2.5 half-life. Then from 80 to 40, it will take 1 and 1. It will take 2 half-life. Okay. Then from 60 to 30, half 60 to 30. 30 will be below this, like 40 to 20, in between. It will be 1.5 half-life. So this 100 is nothing but plasma concentration. So look at the relationship between plasma concentration and T half. As the plasma concentration decreases, 100 to 80, 60, 40, T half 2.5 to 2, 1 point also decreases. Means the things are decreasing in the parallel manner. So we can say this is directly proportional. If it is decreasing, it is also decreasing. Second parameter is rate of elimination and clearance. Only these three questions or four questions are asked. Second is rate of elimination. Means how much eliminated per unit time. 100 is there, then 50. It means in 1 hour, 50 is eliminated. In second, 50 to 25. 25 is eliminated. Then 25 to 12.5. 12.5 is eliminated. Similarly, in this case, how much is eliminated? This is 100 or this is 80. 100 to 80, 20 is eliminated. 80 to 60, 20 is eliminated. Again 20. So the rate of elimination. So rate of elimination means how much is eliminated, and the next concept that is related is the clearance. Clearance is a hypothetical concept, and this concept will tell you about the rate of elimination divided by plasma concentration. So this is 50, 25, 12.5. So we can say the rate of elimination. Every time this rate of elimination is decreasing parallelly with the plasma concentration. So we can say rate is directly to plasma concentration. As this is decreasing, 50 to like this is also decreasing. So rate is directly to plasma concentration in case of first order kinetics. But in case of second order kinetic, every time the rate of elimination is 20. 100 to 80, 20. 80 to 60, 20. So rate of elimination is constant in zero order. And the second parameter is the clearance. Clearance is a mathematical concept like 100 to 50, 25, 12.5. Clearance equal to rate by plasma concentration. What is the rate of elimination here? 50. So 50 divided by this 100, that is 0.5. Next, clearance 50 to 25. 25 elimination divided by 50, 1 by 2. That is 1 by 2 is also 0.5. So in case of first order kinetic, every time it will come 0.5. So clearance is also constant, rate is also, rate was directly to plasma concentration, but T half was constant, every time 1 hour. So these are three parameters. In case of zero order, if you look at the clearance, that is rate by plasma concentration. Rate of elimination is 20 per hour divided by 100, that is 0.2. Next, 80, this is 60, again 20 by 80 equal to 0.25. So from 0.2, it is increasing to 0.25. Then again it will increase. So we can say again it will find that 0.3. So as the concentration is decreasing, 80, 60, 40, but clearance is increasing, 0.2, 0.25, 0.33. They are inversely related. So clearance is inversely related to plasma concentration. So in first order or second zero order kinetics, if we summarize, they will ask you first question, what is constant? Fraction. Here, what is constant? Amount. Then rate directly to plasma concentration. Rate is constant. T half constant. Then clearance also constant. Then in case of T half, directly to plasma concentration, and clearance was the inversely to plasma concentration. So these are the four things you need to memorize, or if you want to calculate, you can put these examples of first order or zero order from 100 to 50, 50 to 25. In case of zero order, 100 to 80, 60, 40, 20. You can easily calculate in your exam also, because the formula for rate of elimination is how much eliminated per hour, that is time. Clearance is R by PC, and T half is nothing but T half in how much time it is reducing to 50%. So these were the first order or zero order kinetics. So most of the drug follow first order kinetic, and for zero order kinetic there are few examples, that is 0 watt power, that is warfarin, alcohol, tolbutamide, and P for phenytoin. So these are given in module that these are the 0 watt power. 4 to 5 examples for zero order kinetic, and most of the drugs they follow first order kinetic. So ending this concept, here I want to explain one more example so that this zero and first order becomes clear forever. Look, my question is, why some drug follow first order and why some follow zero order? This is the question. Why some follow first order and This is the last topic of today's class. And why some follow first order, why some follow zero order. For example, in our body, suppose there are 1 lakh enzymes that we call surplus. There are 1 lakh enzymes. Suppose 1000 drug molecules are given. Okay. So out of these 1 lakh enzymes, how many will come? 1000 enzymes will come and they will metabolize 1000 drug. If I increase the dose 20,000, then again out of this 20,000 will come. They will metabolize this within 1 hour. If I increase the dose to 90,000, again we have surplus enzyme. Out of these 90,000 enzymes will come and they will metabolize in 1 hour. If I increase the dose to 2 lakh, now we are having 1 lakh enzymes and 2 lakh drug molecule. So we cannot do anything. Only 1 lakh will metabolize the 1 lakh molecule of drug. It means up to this point, 90,000, this is following first order kinetic. After it becomes 2 lakh, 4 lakh, 5 lakh, a constant amount will be metabolized and that constant amount is 1 lakh. Because our body is having only this much enzyme. So before you reach the saturation, it will follow first order. From 1 lakh, like initially we have 5,000, 20,000, then 90,000. Now 2 lakh molecule. We have only this much. So this enzyme will metabolize only 1 lakh. Next time, suppose we increase the dose further, 4 lakh, again 1 lakh will metabolize. So in this case, amount is fixed. A fixed amount. Before that, in 1 hour, 5,000, 20,000, 90,000, it was following first order. After the saturation comes, all the 1 lakh enzymes are saturated. Now, if you increase the dose to 4 lakh, 5, 10, 20, it will metabolize same amount, that is 1 lakh. So, any drug which is following first order kinetic may follow zero order kinetic at high doses. So, drugs may follow zero order kinetic at high doses. So this is the reason why some drugs follow first order and zero order. The reason for first order, we have surplus enzymes, and the reason for zero order, enzymes are saturated. And because of this saturation, zero order kinetic is also known as saturation kinetic. And because of this surplus, first order kinetic is also known as linear kinetic. So this was the reason that why some drugs follow zero order kinetic and why some follow first order kinetic. So this finishes our pharmacokinetic portion. Tomorrow we'll do pharmacodynamics plus some small topics, and then we'll start chemotherapy, and I think it will take 4 lectures to complete the pharmacology. So any doubt for today's lecture? You can ask. We have 5 minutes, 10 minutes. Any questions in that module you have read and not understood? सब सो गए क्या?
No, sir.
In phase 2 reactions, some of the exceptions are there in dog, cat, something. Can you explain that?
Please repeat your question. I think your voice is not clear.
Sir, in phase 2 reaction, some of the
Hello.
exceptions are there in the case of cat, dog, and pig, like that.
Okay. Exception. Okay. There is phase 2 reaction. Okay. We have cat, fish, swine, dog, and birds. Okay. In case of cat, enzymes, that enzyme may be less or deficient. So this is the case of glucuronide transferase that carry out the glucuronidation enzymes. But in case of fish, the donor is absent. Donor means there is UDP GA. GA means glucuronic acid, and this is the UDP. So this is the donor which is having GA with it. GA. So this donor is absent. So if an enzyme is there but no donor, suppose just a minute. Suppose in phase 1, okay, this is your phase 1 metabolite, and you want to conjugate your glucuronic acid, that is endogenous molecule. Suppose you want to connect this molecule with the help of GTase enzyme, glucurotransferase enzymes. So to attach this molecule, you need the source of this molecule. And the source of this molecule is UDPGA. If this source is not there, then GA will not be there. So to transfer this GA molecule with the phase 1 metabolite, we need a donor. Similarly, in case of methylation, the donor is SAM, S-acetyl something, SAM. For other reaction, we have PAPS, like. So these are the donors. They will donate the molecule and fuse, combine that or conjugate that with the phase 1 metabolite to make it more water soluble, so that it can easily excrete out of the body. So in case of cat, the activity of enzyme is absent or it is reduced. So because of that, if you give paracetamol, okay, if you give paracetamol, that is metabolized by the glucuronide transferase, that enzyme is less or deficient, then it will cause the toxicity. So paracetamol we cannot use in cat. In case of dog, in case of swine as for sulfation. So sulfation is absent. There is sulfone, what we call sulfone, sulfate transferase enzyme, like that. That process is absent, sulfation. In case of dog, fox, what is absent? Acetylation. Acetylation is absent. In case of birds, what is present for conjugation? That is ornithine. And one more, they will ask you most common amino acid which take part in conjugation, that is glycine. Or out of 4 to 5 conjugation processes, phase 2 processes, there is one process known as acetylation, very important. This acetylation is not a true process. It is not a true detoxification process. Why? Because if you remember the aim of detoxification, the aim is to make a drug more water soluble. This acetylation is not following the aim. What acetylation does it? It decreases the water solubility. So the aim of detoxification is this, to increase the water solubility. If our method is decreasing, acetylation is decreasing the water solubility, and it is promoting what? Crystallization, crystal urea formation. That's why this is the reason why the acetylation is not a true detoxification process, because it decreases the water solubility. So acetylation is not a true detoxification process, and it promotes crystal urea. So this acetylation is absent in dog. So, if you remember sulfonamides, okay, sulfonamides, they are mostly metabolized by the process acetylation. So in case of dog, if you do not have acetylation, it is good or bad? It is good. Why? Because in case of dog, if acetylation is present, suppose it is present, then it will decrease the water solubility of sulfonamide. That will lead to crystal urea. That will cause damage to the kidney. So dogs are less susceptible to crystal urea as compared to cattle. Why? Because in case of cattle, there is extensive acetylation. What does it mean? Extensive acetylation means more you do the acetylation, it will decrease the water solubility. Less and less. It will decrease the water solubility, that will lead to crystal urea. So if you want to compare cattle versus dog, so in case of cattle, extensive acetylation make it less and less water soluble, more prone to crystal urea, even though we say that canine have this acidic urine, and we say herbivores are having alkaline urine. And then we say in alkaline urine, the chances of crystal urea and the chances of acidic urine, crystal urea are more. But even though it is having alkaline urine, but because of this extensive acetylation, this factor is overcoming over this alkaline urine. So because of extensive acetylation, water solubility of that compound will decrease, and it will lead to crystal urea even in the presence of alkaline urine. But in case of dog, this is absent, no acetylation. So what is there? If acetylation is absent, then who will metabolize sulfonamide in dog? So that is by the glucuronidation. Okay. So in different species, same drug will be metabolized by different pathways. It means in case of dog or in case of cattle, example is in front of you. In case of dog, sulfonamide is metabolized by glucuronidation, and in case of cattle, sulfonamide is metabolized by acetylation. So drug is same, sulfonamide, but in different species it follows different pathway. So glucuronidation is there to metabolize this sulfonamide, and in case of cattle there is acetylation. Remember, this acetylation is not a true process, it leads to crystal urea formation. I remember this crystal urea. There are only, in chemotherapy I will tell you, there are two kind of drugs that leads to crystal urea. If you remember, there are two, and both are synthetic. One is sulfa, another is fluoroquinolones. Just for your MCQ purpose, they will ask you which of the following drugs may lead to crystal urea. The answer will be sulfonamide and fluoroquinolones. So this was about phase 2 reaction, that is conjugation with exception. Any more doubt? समथिंग एल्स, कुछ और?
Sir,
Absorption,
what about
distribution,
second pass effect?
metabolism. Which one? Hello? Please repeat your
Second
question.
pass effect.
Second pass effect.
Yes, sir.
You are asking about second pass effect.
Yes, sir.
First
Yes.
time I have heard this term. There is nothing like second pass effect. We always read first pass effect. First pass effect means first time when the drug is passing, like from the GIT. There are many enzymes. They will destroy our drug. Second is liver. If you call this one as first pass, first time it is passing through GIT, then this will be your first pass. If after GIT the same drug is also metabolized by this, I think they will call this second pass effect. But in many, like Harpal Sandhu or the foreign author book Pepich, this second pass effect term is not given. So I think they may be calling this as first pass and this is second time. But whatever it will, it may be that first pass or second pass. The concept is the same, that the drug will be degraded either by GIT or by your liver. And because of that degradation, what will enter into circulation? That will be your bioavailability. If it damage destroy 20%, destroy 30%, it will reach 50% here. So whatever be the pass effect, they will affect bioavailability, because this will this is very important, because this is the molecule, these 50 molecules are responsible to produce action in your body. So this and in case of the sublingual route, IV route, all those routes where liver is not included, you directly injecting directly into the blood, that they in that case there will be no first pass, no second pass, only absorption phase. So absorption, distribution, I think apparent volume of distribution you all are clear now. Apparent VD, why it is called apparent, why what is true VD. So then I think absorption, three processes, ionization, HH equation is clear, and one topic is left, that was ion trapping. Okay, I forgot to tell ion trapping. Ion trapping means when a drug moves from one compartment to other. Suppose this is blood, okay, and this is rumen, and this is the udder. This is the udder. They say this ion trapping concept, they have asked one MCQ in Tanwa's Tamil Nadu PSC 2020. When drug, suppose there is weak base, okay, when drug move from one compartment to other compartment, pH of blood is 7.4 and rumen is 6.6, suppose 6.4. It is having range, but it is acidic. Okay, so when my weak base is moving from the blood into the rumen, let's take it into the rumen. pH is acidic and my drug is basic. When both are opposite, it will ionize. Ionized form cannot cross this rumen or these membranes. It means it will be trapped inside the rumen. Similarly, if you come to udder, there is a milk. What is the pH of milk? 6.4, 6.5, 6.6. that is acidic pH. If my weak base move from blood to the milk, okay, then pH of milk is acidic, my drug is basic, both are opposite, it will ionize and it will be trapped inside this. This concept is known as ion trapping. I can give one more example to you of ion trapping. Okay, this MCQ was related with the milk in 2020, that a weak base, when they enter this milk compartment, they get trapped. This is known as ion trapping. When drug move from one compartment to other, it will trap. Similarly, if I make, suppose not weak base, if I make it weak acid, and if I take this to the udder, now pH of udder is, that is milk, is acidic, my drug is acidic, both are same, acidic. Drug will not accumulate, it will not stay here, it will come back to the blood again. So
Sir,
in
one
this
more
case
doubt.
there is okay,
Sir, weak acidic drug means it's more towards basic.
weak, please repeat.
Weak acidic means is more towards basic or completely acidic.
I'm not getting what you're saying. Weak acidic means more basic. Okay, let me explain you once more. Okay. In case of ion trapping, I will give one more example. Suppose there is a dog, and this dog is intoxicated. There is one poisoning, salicylic acid. Means acidic drug poisoning. Okay, there is poisoning. As I told you, if you look at the structure of the kidney, these nephrons, both acidic or basic, lipid soluble, water soluble, they will filter out here. This is the acidic drug. And the urine of this dog is also acidic. Urine is also acidic. So this, in acidic media, this acidic drug, it will cross and will again enter into the blood. But we want to remove this drug into the urine. So what we do, we give sodium bicarb. Sodium bicarb make the urine alkaline. It will make the urine alkaline. Now drug is acidic and we have made the urine alkaline. Acidic drug in alkaline, opposite pH, it will ionize. And ionized form will not cross this barrier. So ionized form will be removed through the urine. So what we do in case of acidic drug poisoning, we make the urine alkaline by using some compound that is more commonly sodium bicarb. You can use acetazolamide also. And in case of basic drug like amphetamine, we make the urine acidic with the help of ammonium chloride or vitamin C. So in case of acidic drug poisoning like barbiturate poisoning or salicylic acid poisoning, we give sodium bicarb. So what is the concept behind this? The main basic concept or funda is we make it more ionized. We create more ionized form of the drug. Because if it is unionized, it will cross and again come back into blood. We make it ionized, means water soluble, and it will be excreted out in the urine. So this is one more application of ion trapping. So because of changing the pH, see, if we change the pH, when we move from one compartment, that is blood, to the urine, pH changes. And if drug is same and pH is same, it will come again back into blood. If drug is same, but if by giving sodium bicarb, if we make the urine alkaline, drug is acidic, urine is basic, it will ionize. And ions never cross this membrane, lipid membrane. So they will come out into the urine. So this application we use for treatment of poisoning, in which case there is no antidote. So in MCQ they will ask you that there is a dog having poisoning of barbiturate. So barbiturates, they do not have antidotes. There is no antidote. Like if you read in arsenic, lead, and they have like dimercaprol, calcium EDTA, and for chloride something, for cyanide you have sodium thiosulfate plus that thing. But barbiturate, they do not have specific antidote. But BZD, benzodiazepine have one antidote. What do you call that? Flumazenil. And opioids also, if there is opioid poisoning, they have naloxone. But barbiturate, they do not have specific. So how to remove their poisoning? So we make the urine alkaline. Because of that alkaline nature, drug will trap and it will come through the urine. So this is the case where if you do not find any antidote, we can utilize this ion trapping mechanism. We make the urine alkaline and flush the thing out. So this was the concept of ion trapping. कुछ और? Any more question? Like metabolism, first pass, then bioavailability and apparent VD, first order, second zero order. Then one small topic is two definitions are there: loading dose and maintenance dose. There are two doses: loading dose and maintenance dose. Just remember their formulas: plasma concentration into volume of distribution, and maintenance equal to clearance into VD. Loading dose is the initial dose, high dose to achieve quickly. That was asked in 2012. Then what is the definition of loading dose? It is the initial high dose to make the concentration, achieve the concentration very quickly. So I will explain this loading dose with one graph, for example. Okay. Suppose let's take one example of that drug, antiarrhythmic drug like amiodarone. Okay. Half-life of amiodarone was 8 weeks. Make a graph and come to the this is first half-life, then again we given second, then third, then fourth, then fifth. So in 5 half-life, 3, 4 and 5, it will become stable. Okay. In 5 T half, it will become stable, mean it will reach at the steady state. But these 5 half-life will take 40 weeks. But the patient is suffering from arrhythmias. We cannot wait to achieve this steady state for 40 weeks. 40 weeks में तो patient ही मर जाएगा. He will die. So we cannot wait for 40 weeks. So what we do at the initial point here, we give loading dose. Okay, we give loading dose to achieve this side plasma concentration rapidly. Then what we do, we give small dose that are maintenance dose. So this dose, this heavy, this loading dose, this is known as loading dose. So besides waiting for 40 weeks, what we do, we give loading dose to achieve the concentration rapidly, and then we keep on giving maintenance dose so that steady state will be remaining constant. So this loading dose depend on the volume of distribution, and this maintenance dose, why we are giving daily maintenance dose? Because of clearance, because the kidney will clear the drug, then we again give, then we again. So this is the maintenance, and initial high dose is the loading dose. So without waiting for these 40 weeks, we can start, or we can control arrhythmia within the first week itself. So this is the concept of loading dose and maintenance dose. Loading completed, maintenance, clearance. Clearance means simply that how much plasma you cleared from the drug, and that clearance may be cleared by the your kidney, called renal clearance. If cleared by the liver, then we call it hepatic clearance. Then filtration calculation, I think it's phase 1 to over VD. Anderson equation is there. Trapping facilitated. So any other doubt? सब लोग सो गए क्या?
Dose response curve.
Hello. Dose response curve, that is part of pharmacodynamics, not kinetic. Okay, that will cover in tomorrow lecture. Pharmacodynamic, like DRC, types of research.
Okay, sir. Okay, sir.
That way. Pharmacokinetic involved in this for ADME, like absorption. What happens with the drug? So this was the starting of our lecture. We administer the drug, then we take it into the circulation, that was absorption. Then again crossing membrane, that was distribution, where the role of plasma proteins was there. And after distribution, metabolism, phase 1, phase 2, and then it was kidney, removing the things by glomerular filtration, some drugs by tubular secretion like penicillin, and by tubular reabsorption. So this was ADME processes known as pharmacokinetic. And the determinants we studied, how to measure absorption, that parameter was bioavailability. How to measure this distribution, parameter was apparent VD. For elimination, how to measure that? We had T-half, clearance, and then steady concentration state. The last topic was order of kinetics. That was first and zero order. So this is the summary of today's lecture. ADME processes and their determinants and how to measure them. It's 11:53. So should we close today's lecture, or any doubt? Something is left from your side? This pharmacokinetic, because pharmacodynamic is very simple. It will take less time, but kinetic portion is, in pharmacodynamics there are 4 types of receptors and DRC curve and agonist, antagonist, like that. potentiation, small topics are there. Hello.
Sir, there was this question in the module pharmacokinetic parameter of morphine include VD 400 liter per 70 kg and CL 600 ml per minute and oral viability fraction was 0.25. What will be the loading dose to achieve a steady state level of 25 mg per liter? Could you please explain that?
Okay. There is one more formula for that loading dose. That is steady state concentration into what is given there in the module. That formula.
So in the module it is written loading dose is VD into steady state divided by viability oral viability fraction.
Okay, VD into CSS divided by bioavailability. So yes, it was simple loading. It's formula for the loading dose. Because if you give by other route, no, then we have to consider this F, which is nothing but bioavailability. If you are giving the drug by IV route, then we remove this F portion. Then the formula will become VD into CSS. Then VD value is given and CSS value is also given. Just multiply them, you will get the loading dose. So why we consider bioavailability? Because for IV, drug will 100% reach into your circulation. So no need to take this parameter into account. So we just write VD into CSS. But if other route, like you take orally, then this factor come into play. F, that is bioavailability. So this was simply a formula based question they have asked. Then and it was given that 400 liter, 400 you can multiply 400 into 25 mg. 400 into 25 to convert. I think it was 25 mg steady state. Okay, then 400 VD divided by 0.25 to cut this and make this point clear. You will get this 40 mg. So it was simply formula based MCQ. Then there is one MCQ what causes apparent VD of a drug to exceed total body fluid volume? Sequestration in body tissues. What does it mean? There is one drug, chloroquine, having volume of distribution equal to 1300 liters. But in our body, the cardiac out or the volume of blood is 5 liters. So the VD is more than our body fluid volumes. It means this is an apparent parameter. VD means the drug in the plasma. So as I explained you, high VD means high distribution. It means most of the drug have entered into the tissues. We use the term sequestration. The drug and sequestered into the tissues. More it enter into the tissues, less will be in the blood. So more distributed and it will give more apparent VD volume, like chloroquine having 1300. So this is the meaning of sequestration, where the drug is highly lipid soluble, it leaves the compartment of blood, and having high affinity, it will enter into tissues like liver, or it may having affinity for retina. So liver or retina and other organs. So this apparently gives you the 1300 liters. So more VD means more distribution into the tissues. Then there is one more question that drug A has apparent VD 100 liter, B has apparent volume of the 5 liter. Both are given orally, which may require loading dose. So it's a simple question that VD 100 and second is having VD 5 liter. Because loading dose equal to plasma concentration into VD. Then clinical importance, okay, it's then significance, plasma protein, bioavailability. Okay, so pharmacokinetic portion is over. Please solve all those MCQs which are given in a repetition course exercise at the end of the module. Tomorrow we will discuss pharmacodynamic, that what happens with the body. Means body is having multiple receptors, it will respond, how does it respond? We'll see all these things tomorrow. So I am closing today's lecture. Thank you for joining, all of you.
Thank you, sir.
Thank you.
Thank
Good
you,
night.
sir.